Let's continue. Okay, so resuscitation formulae or resuscitation formulas. Formula crystalloid volume, colloid volume, free water. Parkland 4 ml per kg per percent, TBS burn none. Brook 1.5 milliliter per kg per TBS burn, 0.5 ml per kg per percent, TBS burn 2 liter. Free water. Galveston pediatric 5000 ml per meter square burn area plus 1500 ml per meter square total area none. Topical antimicrobials used in burn: silver sulfadiazine cream. This gives broader spectrum prophylaxis against bacterial colonization, particularly effective against Pseudomonas and MRSA, most commonly used. Silver nitrate solution 0.5%, highly effective as prophylaxis against Pseudomonas colonization. Not as active as silver sulfadiazine cream against some of gram-negative arrows, and it needs to be cleansed or the wounds resoaked every 2 to 4 hours. Produces black staining of all the furniture surrounding the patients. Popular in the USA, painful to apply, associated with metabolic acidosis. Useful for full thickness burns, induces a hard effect on the burned skin. In elderly patients, to reduce cell-mediated immunosuppression, sodium nitrate forms a sterile scar and boosts cell-mediated immunity. Most common cause of death at the site of burn is asphyxia. Most common cause of death in burn is septicemia. Most common cause of early death in burns is hypovolemic shock. Most common cause of late death in burns is septicemia. Most common organisms responsible for sepsis in burns: Pseudomonas. Post-burn neck contracture. Cervical contractures are major problems in burn involving the chest, neck, and face. Severe neck flexion contracture in the acute phase often requires early reconstruction to aid airway management. Neck contractures should usually be dealt with prior to facial burn reconstruction, as the extrinsic contractile forces from the neck can cause facial deformities and can adversely affect maturation of scars on the face. When split thickness skin grafting is unsuccessful because of recurrent contracture or does not provide a satisfactory aesthetic result, local flap reconstruction of anterior neck is an excellent technique. Perioral deformities: macrostomia, irreversible damage to dentition, loss of jawline deformation. So anterior neck contracture in the acute period are best prevented by aggressive splinting and incision release and grafting when indicated. Deep second and third degree burns do not heal in timely fashion without autografting. Sclerotomy is done in case of deep second and third degree burn wounds to decrease constriction of a scar. Low tension injuries. Low tension or domestic appliance injuries do not have enough energy to cause destruction to significant amount of subcutaneous tissues when current passes through the body. Resistance is too great. Entry and exit points normally in the fingers suffer small deep burns. This may cause underlying tendon and nerve damage, but there will be little damage between. The alternating current creates a tetany within the muscles, and the patients often describe how they were unable to release the device until the power was turned off. A common finding in patients with electrical burns is myoglobinuria manifested as highly concentrated and pigmented urine. Main danger with these injuries is from alternating current interfering with normal cardiac pacing. This can cause cardiac arrest. The electricity itself does not usually cause significant underlying myocardial damage, so resuscitation, if successful, should be lasting. And the very important and good thing regarding to this thing is every question's answer has explanations, and the explanations also has a great capacity to boost up most important points in theory. Let's go for that. Barker formula to estimate burn size percent. Body part 0 to 1 year, 1 to 4 year, 5 to 9 years. Head 19, 17, 13. Neck 2 to 2. Anterior trunk 13, 13, 13. Posterior trunk 13, 13, 13. So only the difference is between different ages in head percentage. I mean to say the area covered in head percentage 19, 17, 13, and others are almost same. Okay. Wallace. Okay. So hint for 5, I guess. Yeah. In children younger than 3 years old, even we read it just like this. Okay, we will get a lot of hint to crack MCQs. In children younger than 3 years old, the head accounts for a larger relative surface area and should be taken into account when estimating burn size diagrams such as one and broader chart give a more accurate accounting of the true burn size in children. For children and infants, the Lund-Browder chart is used to access the burned body surface area. Different percentages are used because the ratio of the combined surface area of the head and neck to the surface area of the limbs is typically larger in children than that of an adult. A child has circumferential burn of both thighs 13, buttocks 5, face and scalp with sinking of hairs 17, total burn 13 plus 5 plus 17, 35. Burko diagram. I have to underline the important word which I couldn't pronounce it very well, or I have confusion in its correct pronunciation, because pronunciation must resemble with American English that I follow. Burko diagram to estimate burn size based on area of burn in an isolated body part. Body part 0 to 1 year, 1 to 4 year, 5 to 9 year, 10 to 14 year, 15 to 18 year, and adult. After 18 years is adult, okay. And we are looking at the chart, so I'll just go on reading the digits, and we have to keep in mind. Head 19, 17, 13, 11, 9, and finally 7. Neck 2, 2, 2, 2, 2, 2, all 2. Okay, anterior trunk 13 for all, posterior trunk 13 for all. Right buttock 2.5% for all, left buttock 2.5 for all, genitalia 1 for all, right upper arm 4 for all, right lower arm 3 for all, and right hand 2.5 for all, left hand 2.5 for all, right thigh same 5.5, left thigh 5.5, right leg 5, left leg 5, right foot 3.5, and left foot 3.5 for all. We have to review the age group according to this Burko diagram: 0 to 1 year, 1 to 4 year, 5 to 9 year, 10 to 14 year, 15 to 18 year, and finally adult. Sclerotomy is when deep second and third degree burn wounds encompass the circumference of an extremity. Peripheral circulation to the limb can be compromised. Development of generalized edema beneath non-yielding scar impedes venous outflow and affects arterial inflow to the distal beds. This can be recognized by numbness and tingling in the limb and increased pain in digits. Initial flow can be accessed by determination of Doppler signals in the digital arteries and palmar and plantar arcs in affected extremities. Capillary refill can also be accessed. Extremities at risk are identified either on clinical examination or by measurement of tissue pressure more than 40 mmHg. These extremities require sclerotomies, release of the burn scar by incising the lateral and medial aspect of the extremity. Electric burns are both superficial and deep depending upon the thickness involved. Corollaries to the Land and Davis formula are fitting formulas of burn patients. Percentage of burns into weight kg into volume in ml. Half of the fluid is given in first 8 hours and another half in next 16 hours. Management of burn wound, exposure method and closed method. No dressings are applied over wound after application of agent to the wound 2 to 3 times a day. Used for face and head. Disadvantages: increased pain, heat loss, sorry, risk of cross contamination. Closed method: occlusive dressing is applied over the agent and changed twice daily. Generally, closed method is preferred. Advantages: less pain, less heat loss, less risk of cross contamination. Disadvantages: potential increase in bacterial growth if dressing is not changed twice daily. Initial management of the burned airway. Early elective intubation is safest. Delay can make intubation very difficult because of swelling. But be ready to perform an emergency cricothyroidotomy if intubation is delayed. IV fluid resuscitation in children with burn more than 10% TBSA, an adult with burn more than 15% TBSA. RL is preferred agent for resuscitation for the initial 24 hours. Nasogastric intubation is done to decrease the risk of emesis and possible aspiration as a paralytic ileus develops in the patients. And patients of burn. Dextran is a colloid that can be used after 24 hours. However, albumin is preferred and most widely used colloids. In burn management, topical antimicrobials are used. Pseudomonas is most common infection in burn patients. It has replaced streptococcus and staphylococcus because of availability of good antibiotics. Toxic shock syndrome is most commonly associated with tampon use in menstruating females. It is caused by staphylococcus infection producing TSST1. Damp dressings should not be used.